Hi, so I'm Brian Betz, part of Indiana State University's Doctor in Athletic Training program. Today I'm just going to go through a little bit of my clinical framework. So let me share my screen here. And so we'll start off with our journey. So just kind of going through my clinical framework. We're going to use mock patient Amoy as my dummy here. Amoy is not a real patient. He is someone who I came up with. So say hi to Amoy. He's 16 years old, male, soccer player from Fort Lauderdale, currently living in Philadelphia, Pennsylvania. He is of Jamaican descent and plays soccer for a youth development academy with aspirations to play soccer professionally, kind of right out of high school. So he's still in high school, but attending this academy. So what our pre-participation examination for Amoy reveals, right? There isn't much in terms of past medical history. A few big red flags. He's positive for sickle cell, but other than that, has no other family condition or has no history of heart conditions. No tobacco or alcohol use, allergies, asthma, anything like that. No surgeries, no medications. Really got nothing going on, except the other thing is orthopedic history. He has multiple rolled ankles, which shows up on his ortho screening in terms of some provocation tests and decreased balance on the Y balance test on the right in the posterior, lateral, and anterior directions. Um, Psychological history or well-being, according to the PHQ-2, scored a 1 out of 2, which is good. And just some dietary needs of his, he is a vegetarian. So with that information, we send him to our team nutritionist and have him meet with them to make sure that he's getting the appropriate protein and B12 and iron that he would need to compete at a high level in order to do this. So to compete and do that. So moving forward, right? So what did I do? I know what sickle cell is. Just want to get a refresher, so I went to the NATA position statement, and right, Amoy, right, some of the recommendations that limit his extreme exertion, be aware in the heat, and really make sure he hydrates and takes plenty of water breaks and plenty of breaks to let his body recover. Um, and then in terms of it just kind of keys for recognizing a screening, so and he's aware of these as well. So just kind of making sure he's doesn't feel weak, tired, exhausted, has any sort of cramping, and really make sure that he feels pretty good, generally speaking, without getting into too much of the details. But refer back to this and how to treat him just as a guide for me moving forward, just as kind of a little bit of a refresher. And so what does this mean for him as a student athlete? So now Moy's been playing soccer since he was 4 years old, so he's been doing it for a while. From the Nagy disablement model, his red blood cells that are sickle shaped will obstruct his blood flow, so it doesn't allow him to get blood to the area, which can cause the cramping, and it gets worse in the heat. So things he'll experience, right, is cramping, swelling, weakness, fatigue. And that will lead to him, needing to take more frequent breaks. So every 10 minutes of strenuous activity, he'll need to take a break, especially in the heat. So for him, this kind of limits him to, right, keeping in mind he wants to play, he wants to go pro, right? So kind of balancing his goals with his limitations, he's going to be limited into the positions he can play. So he can play goalkeeper and he can play center back. And that's important to communicate that with coaches, just because those positions don't have quite as much high intensity running. It's more kind of like a trot or a jog. And then maybe every once in a while you'll get not a big sprint, but a fast sprint. And then from a social perspective, right, we may have to adjust any sort of conditioning we do with him to make sure that gets the he gets the proper breaks that he needs in high heat, right? When everyone else is when it's kind of on that borderline where maybe they should take breaks, Amoy will definitely have to take breaks on his own, and this could lead to uh, some feeling of isolation, feeling separate and different from the team. So that's just something to be aware of, and maybe something to consult with a sports psychologist with. So further screening that I would do for Amoy would be just kind of get an idea of when his last episode, if he had any past history or episodes of sickle cell, which he did at age 9, and making so from that we can kind of determine, okay, he hasn't had any real issues with it, and then that kind of opens up a conversation about how he, can he feel it coming on, and his experience with that, and making sure that we're on the same page, and how closely, obviously we monitor him closely, but we provide things maybe like ice towels, uh, a timer so that we know, okay, it goes off, Amoy needs a break. So that kind of thing from the sickle cell perspective. And then from the single, we also want to get with his chronic ankle instability, a single leg landing arrow scoring system, but onto a force plate, which I'm fortunate enough to have, and just have him do that, see how long it takes him to stabilize, because that is a good predictor. It kind of helps us evaluate, and when he's changing directions, can he, how long does it take him to stabilize so he doesn't roll his ankle? Because that's really, if he doesn't stabilize, he's gonna invert, since he's already predisposed to it. So it'll kind of help us get an idea of how unstable his ankles are as compared to a healthy individual, because we can find norms for that, as well as testing him monthly to see if we can improve based on what we're about to get into, our daily injury prevention program that we give him. So for 5-10 minutes before practice, he'll go through a progressive ankle exercises, balance, proprioception, strength, some plyometric stuff, kind of to build, kind of improve his ankle stability, as well as specifically for Amoy, right? Some frequent cooling and hydration breaks in a excessive, especially in a high heat index or with a high intensity practice. And then going back to his ankle, we can tape him if he wants. I'm not a big fan of tape, as I think it helps, right? It helps atrophy some of the muscles that are used to stabilize. But I do think that if he feels that he wants it, we can tape him, and it's a matter of, can we, right? Like, does he prefer the tape? Does he not prefer the tape? The braces are, seem to be better, but typically soccer players don't like braces. If he wants a brace, we can order one for him. And then from a team-based perspective, right, we're gonna have a team warm-up that kind of focuses on everything from neuromuscular control, stability, strength, agility, mobility, and kind of incorporate plyometrics, and kind of, it's just going to build on itself, really to prepare the team for training to reduce the risk of injury. The other thing that we would do, or I would do, is have the athletes or patients do high-speed runs once a week, because it is shown to be good for hamstring health and reduce the risk of hamstring injuries. And then also, one thing that I would like to do would be track fatigue and adjust training accordingly, really using RPE that the boys can fill out daily or weekly, and then a vertical jump test that we kind of take a select sample of a few boys on each of the teams, have them do a vertical jump test, see where they fall, and kind of track if they're, are they feeling fatigued? Are they supposed to be feeling a little bit fatigued at this state? And we can kind of go from there. So then in one of our games, this happened to Amoy, where he just kind of pulled a hamstring. This isn't Amoy, but this is the same kind of instance that he had. And so first thing I had him do was I had him fill out this soccer specific outcome measure that I came up with. And I like it because I created it, but also because it it puts terms into it puts things into terms that soccer players can understand, and they get it. And it's also, we can kind of give this to coaches, and it kind of helps us communicate well with the coach. Like, if they're saying, "Oh, why can't he do something?" It kind of says, "Well, he's having trouble striking a ball, or he's having trouble changing direction," and that can be backed up here, but it also helps us obviously track our progress, um, as well. And I also think it helps. Most of these boys want to play professional soccer, so in Amoy's case, he wants to play professional soccer. He can see, right, I have pain doing this, I have pain doing that, I have pain sprinting, cutting, changing direction, um, and so that kind of puts things into perspective. Like, maybe I can't play. I probably can't push through this if I can't do, 7 out of the 9 things that are on here without pain. So I think it's good in kind of connecting the dots for them as well. So then we kind of get into Amoy now starts his rehabilitation or reconditioning process. And here I have the NAGI disablement model kind of overlaid over a reconditioning model that I recently learned. And so the injured Amoy in this case, right, obviously has stretched, for grade 2, is a partial tear of his hamstring, in his biceps femoris, and then he's injured and is considered injured up until he can kind of get back to his activities of daily living, and then I'll go through all the negative disablement model and how that relates here a little more, but just so you can understand, the injury kind of up until he gets back to walking and full daily activities, activities of daily living. So if this doesn't include any sort of, for him, activities of daily living include soccer, that doesn't come in yet. So it's really until he gets back to walking. Now, once we can get him walking, we'll start doing some reconditioning. So maybe we'll do some metabolic conditioning on the bike. We can start doing some strengthening stuff. We can start teaching him, kind of get the brain going, right, and start to get him doing um, some acceleration drills. So not actually accelerating, but getting into the positions that acceleration occurs in, getting into positions that you need to change direction, more so track style drills, with minimal movement than anything else. And as he progresses through that and becomes, and gets more healthy and has spent some time and he can do these things well, right, and he's strong again, we can let him get back to athletic normal. So athletic normal it's a process, but it ranges from just kind of being able just to run again, right, doing athletic movements. So being able to run all the way through to, being able to change direction, sprint, and it even gets so specific with each part, which with each patient as to, um, like, so for Amoy, it's playing soccer. Can he strike a ball? Kind of doing everything that I just had on that soccer specific outcome measure. And it's important to kind of denote typically, right, where reconditioning ends and athletic normal begins is kind of, generally speaking, where athletic trainers kind of like transition, and that transition of care over to a strength conditioning coach. Um, and so Amoy, right, will then kind of go through athletic normal, um, and then once he kind of gets to athletic normal, right, where he's able to run, jump, cut, pass, um, and do all these things, he'll then start to transition into training, and then he'll kind of eventually, right, so maybe he'll do technical, and eventually he'll go back to full competition, which isn't, it's nothing groundbreaking. It's just a matter of, making sure that he's able to do this. And I think it's just kind of the transition of care between practitioners. One thing I want to point out though is reconditioning will actually continue on all the way through full competition. He might be completing fully, but we're still doing some running, some mechanics work all the way through. And so to get into how the negative disablement model kind of falls in line with this, right? The injured part is specifically pathology. So obviously, we're going to try and meet these goals that I have up there through the methods that we have. Personally, I'm not a big fan of medication, but in an instance where a patient likes medication, well, we can provide that. Um, and then also we can work on his impairment, which by decreasing pain essentially is really his limiting factor, and increasing his range of motion, increasing strength and muscle tone, really working on the isometrics, and overall increasing function until he can get back to his activities of daily living. And at this point, I kind of have him of banging a head against the wall. This image of Amoy banging his head against the wall, as he's so frustrated, right? Kind of pissed off that he's been set back so far that he can't really see signs of coming forward. So and getting back to play. So maybe it's time where we send him, have him talk with our sports psychologist to get him moving forward and get his mind back to the right state. So progressing forward, right after we get through the kind of start to get into the reconditioning phase, uh, he doesn't have right. He's able to change significantly. He doesn't have any issues running or jogging. Very minimal running. Sprinting and striking a ball are still painful. Cutting, changing direction are still painful. But accelerating is still like painful but manageable. And so we continue on, right? And so functionally, right, we're kind of working on, if we start to work on function really in the reconditioning athletic normal phase, that's really where functional takes its place. So really we're going to teach him the mechanics of accelerating, decelerating through doing stationary drills and progressively getting stronger. We'll do metabolic conditioning. We'll do um, strengthening. In the very beginning of this, get any range of motion that he's missing back. Really get the nervous system firing. Try and connect that motor pattern awareness and get the brain comfortable doing those motor patterns again. That's really the goal. And then eventually get him into sprinting, changing directions, and jumping, more plyometric type movements as he kind of gets back into athletic normal. And then so disability, you can kind of see starts all the way from injured through to when he starts to kind of get back into full team training and he's no longer just doing technical. And so really his disability is that he can't play the sport that he wants to play. He can't play soccer. And that makes him feel separated and isolated from his friends and his teammates. Uh, and so, and that can last all the way through until he's completely competing again, um, on top of what he had from his sickle cell. So, right, so there's a little bit more added to that. He feels even more isolated. So he goes all the way through to full competition. And then when he can finally compete in terms of the hamstring injury, he is no longer, uh, in the disablement model from any sort of perspective. So, when he finishes up and he leaves, really by the time he gets to finishes up athletic normal and starts return to training, this is where he should be when he begins his return to training process, where he doesn't have any pain with anything. So looking back, kind of doing some quality improvement, some quality control, we can kind of see here, we kind of tracked a few of our samples for the vertical jump over time. And right about the time of Amoy's injury, right about May 12th, his vertical jump height, or everyone's vertical jump height, was dropping. So it was time to kind of let them get a break. And then Amoy got injured, and he wasn't the only one. We had a few, so we should have stopped that a little bit earlier, and intervened a little bit earlier. And so as we kind of go forward here, right, these are kind of the injuries that we had happen over that same time frame. So that was a 4-week period that you saw here. Over a same 4-week period, no, right, no, or he had like 3 injuries here. Okay, 1 new injury, 3 new injuries, and 6 new injuries. So if we overlay the two, you can see, right, they're not really fatigued, and down here they kind of start to get fatigued, and the injury goes up a little bit, but kind of normal, right? And then um, really we have a spike here when everyone's really starting to get fatigued. So it's important to then go ahead and show this information to the coaches, saying, uh, listen, we think we need to back off. Either it's on our end as a athletic training perspective, strength conditioning perspective, a performance department, or on your end, but we need to kind of work together to decrease the load that these patients are going through. Uh, and so we can kind of educate them using infographics. So this is one that I pulled from an article about high-speed running and hamstring injury strain risk, and kind of just saying that we have to manage it. Sometimes we need more, sometimes we need less high-speed running, but maybe now we start adjusting instead of having a standard. Everyone does you know uh, 600 meters of high-speed running once a week. Maybe we adjust it based on how their exertion is, and then so for Amoy, we continue after his injury. Once he's back fully returned, we continue his ankle prevention work, add some hamstring work to his pre-practice routine to prevent that from happening. We could also individually manage his high-speed runs, like kind of talks about in this infographic, and then continue to track fatigue and RPE to make sure that this doesn't happen again. So this is really kind of where the quality improvement comes into play. And so that's Amoy's only real significant injury while he's with us. And so upon discharge, right, we're just going to test his time to stabilization, see how he's doing compared to that, write a discharge note, close the patient file, uh, and pass along any information. Like when Amoy graduates, pass along any information that his either the university he goes to or the professional team pass that along, um, so they kind of have an idea of his history and what we've done. So that's all I got, and thank you for watching.